Welcome to Pharmacy View Podcast, where we provide regular interviews with pharmacists and key people within Australian pharmacy and the associated global industry. In this stream of podcast episodes titled RX to Riches, we delve into the evolving global pharmacy landscape, exploring the challenges and opportunities, and examining the current state of retail pharmacy across the globe. With each guest, we discuss the hurdles they face and the potential growth areas that may shape a brighter future for your pharmacy or industry-related business. I'm your host, Michael Alexander, pharmacist, digital health enthusiast, and co-founder of Audirie, an AI-powered communication intelligence platform serving the healthcare industry across the globe. My guest today is proudly brought to you by Shopfront Solutions for all your shelf and digital marketing needs, part of the Arion Technologies Group. Welcome to part 2 of our two-part discussion with Dr. Drew Oliveira and Denise Giambalvo. I hope you enjoyed as much as I did.
Well, there's another winner. Well, there's a couple other winners, because you mentioned that, there's 3 PBMs in the US that own 80% of the market. And there are well over 150 PBMs in the US. So why just 3? And the other winner would be consultants who consult with the employers on which PBM is going to give them the greatest value. It's going to cost the least, less, disruption, better service for their employees, because that's what employers care about. Want to make sure everyone gets their drugs so that they can come back to work and be productive. But there's recommending, more often than not, one of these 3 PBMs over a bunch of other ones that may or may not, maybe the other ones aren't very good, or maybe they're too good, or there must be a reason that they recommend those at a disproportionate rate.
Today on RX to Riches, we're delighted to welcome Dr. Drew Oliveira and Denise Giambalvo. With over 17 years of experience in healthcare and insurance, Dr. Oliveira is a seasoned physician leader. He's held senior positions at health insurers Cambia Health Solutions and Aetna, focusing on areas such as utilization management and network contracting. Alongside his corporate roles, Dr. Oliveira has been a clinical associate professor at the University of Washington for over 3 decades. Currently, he's serving as the executive director of the Washington Health Alliance, where he's dedicated to improving healthcare quality and affordability. Denise is a strategic healthcare leader whose accomplishments include forging partnerships for PBMs, developing cutting-edge software for healthcare programs, and spearheading initiatives to manage specialty drug costs. With decades of experience in the healthcare space, Denise has held key roles such as vice president at the Midwest Business Group on Health and executive director at Employers Health Coalition. In her current role as director of member engagement and business strategy at the Washington Health Alliance, Denise continues to drive strategic planning and cultivate key relationships. Welcome to you both.
So how come we don't just put the best drugs on a formulary based on the clinical evidence in the US? Or do we know what the best drugs are?
Well, we have research out there to show us best drugs, right?
Yeah.
And it's the ability to do that is there, but the incentive to make some money on the side is pretty big. And when you have 3 pharmacy benefit managers controlling 80% of the market, it's kind of
And is that
hard to turn back.
So it sounds like that's kind of a shady. So if we got rid of the rebates, then we'd be okay.
Well, no, because
No.
Because we have vertical integration.
Tell me what that's
So they've purchased up other businesses, so they own So the pharmacy benefit manager owns rebate aggregators. They haven't even gotten into 340B pricing, but they could own a 340B.
Can you, for this audience, can you
I know,
explain
so,
what a 340B is? Cause that,
So we do a discounted price on drugs for providers that are serving low-income patients.
it's a good thing.
And it's a good thing. Yeah, right, as they should. And many of them are research centers,
Academic
universities,
medical centers,
yep.
Okay.
And so we wanna help them out, right, because they're doing. But PBMs have found a loophole in the legislation that allows for this. That, and not just the PBMs, but the providers themselves that have the 340B pricing. To also deliver that to people in the commercial market who may not be in need. People are getting drugs at a lower price when from an income perspective, they can more than pay for the drug at a regular price.
Oh, so the higher income patients are getting a benefit.
Yes. Yes.
Well, as a higher income person, maybe I would want that, right? And then, is that the only, now, but we're paying the pharmacists who are dispensing the drugs fairly, and everything that they get paid is the total cost of the ingredients and the dispensing fee.
No.
No.
So there's a few different things that could be happening with that, right? So we
Drug costs
negotiated.
$1, dispensing costs $1, patient pays $2. Employer pays $2. No?
We negotiate prices in advance.
Oh,
So a pharmacy may pay more for that drug, but what's in their contract is that they're gonna receive less. There's also, PBMs will do what we call clawbacks. There's a remuneration process that takes place, where they will go back and they will say, oops, you don't deserve to get all of this money for that drug. And they take the money back from the pharmacy. So
so a pharmacist in their little pharmacy in a little town has to buy the drug,
Mhm.
and they're paying $5 for it, but the rates may have been negotiated, they only get paid $3, so they lose money?
So they lose money. Well, so the other thing is that rarely a pharmacist will buy direct. So they usually belong to a group purchasing organization, right? And so their purchasing power is only as big as their purchasing group. So one group might get better pricing than another. And what you negotiated 6 months ago on a drug, right, may be costing more now. So then you agreed that this, reimbursement was okay 6 months ago, but, ingredient costs have gone up and now all of a sudden you're paying more on that drug. And the PBM says, oops, sorry.
So it's a little hard for these independent pharmacies to stay in practice. But you've also talked about sort of the vertical integration of the pharmacy benefit manager who now owns
A pharmacy.
pharmacies. And they don't have to worry about that sort of acquisition cost as much because they own that whole process.
Correct.
And now,
And sometimes they own providers too.
And they own the providers.
right? So they've got the doctor, they got the primary care docs, they have their own pharmacies, they've got the PBM, they have the rebate aggregator that's typically in an offshore account located in like
Someplace.
the business is in a whole other country, so we don't have full insight into what's going on with them financially.
Yeah, because I think we've started to see some of the pharmacies owned by these large PBMs now taking some of their space and making it into primary care practice, who can then directly just walk the patient over to the pharmacy when they're done seeing them to collect whatever drug they have. So that's sort of that vertical piece. There's a concept that is also pretty prevalent in the US called spread pricing that people may have heard about.
Yeah.
Can you explain what a spread price might be?
Right, so we'll say it's a $20 drug, right? We're getting a 30-day supply. And the plan is charged. Let's say the member has a $5, it's a generic drug, the member only pays $5 for their generic drugs. That's their share of the cost, right? And then the plan pays, the employer, as the plan sponsor, pays the difference.
The other $15.
The other $15.
Great. So it's $20.
So it's 20.
And that pays the pharmacy.
And so that $20 should cover the ingredient cost plus dispensing fee, right?
Yeah.
But when there's spread pricing, what we find is the $20 is covering more than the ingredient cost and the dispensing fee. And what's actually happening is the pharmacy is getting paid, I'm gonna say $16, which is probably more than what they're getting paid. And the PBM is keeping $4 for themselves. And the employer, as the client who is contracted for the PBM to provide this service, is already paying a fee to the PBM. And so they have no insight into this, right? So
the employer pays $20. The whole transaction should be $16. There's an extra $4 that the PBM keeps for, what did the PBM do to earn that?
They're there.
Because
they established
paid the
themselves.
but the employer already paid them to pay claims. So this is like extra revenue that they're creating extra revenue with rebates, they're creating extra revenue with this spread that's in there. They have maybe the vertical integration. I think in the US, our biggest cost within pharmacy are now specialty drugs. Well over 50% of the cost is a specialty drug. I think that, most things that are, molecular based are, being used as generics. So it's that, did the PBMs get involved in the specialty drug pieces?
That's big business for them because they own the big PBMs, the big three, all own their own specialty pharmacies. And they manage the prior authorization. So if you're a patient who was prescribed Enbrel, and the prescription gets submitted to the specialty pharmacy owned by the PBM, that claim triggers for an authorization. So someone within the PBM reviews the claim and approves it, says, yes, Dr. Drew Oliveira should receive this drug, right? And then you pay oftentimes 20% of the total cost. Sometimes there's a a maximum limit on that, right? So some might say 20% not to exceed $200.
Yeah, pretty
So-
common
So let's say,
design.
you pay your $200, they ship the drug out to you, right? Everyone's happy.
I'm happy.
You're happy, kind of. You just paid $200.
Not happy
You're
about
gonna,
the
you're gonna have to pay
but
that
I'm happy they gave me
repeatedly.
my drugs.
But
and
they gave you your drug, it was delivered to your home, all that was nice,
That's nice.
right?
Yeah.
On the back end, the PBM is getting rebates and administrative fees for that drug, right?
Because they put it on the formulary as a preferred drug.
As a preferred drug,
Got it.
and no surprise, they approve the dispensing of that drug about 96% of the time. So they put it on the formulary as a preferred drug, they get money for doing that, and then they're in control of saying whether or not it's appropriate for the patient to receive that, right? Based on clinical information that the doctor sends over.
They're proving it that often, why do that at all?
Why
right?
do that at all? And how do you know that there's no conflict of interest in that approval process in terms of truly making sure that that's the right drug for that patient?
If they don't approve it, they don't get the rebate.
They don't get the rebate
spread.
money. They don't get the money at the
At
pharmacy
the pharmacy side.
either, right?
So it's in their
there's
best interest to
Oh,
approve more often.
and we actually didn't talk about that usually the employer pays for the service for prior authorization to be done.
Absolutely. Mike, we're just leaving you, back there, and we haven't, we're just keep going, but,
No, I love it. I love it. This is actually the easiest podcast I've ever done, which is fantastic. Because
we're just
I
having a
love the discussion.
conversation, we're having a good time.
No, I love the back and forth. I think, there's covered a lot of ground, and just to sum it up, it sounds like there's winners and losers, it feels, throughout this process. And let me see if I can pull out the winners and losers. So a big winner sounds like the PBMs. The PBMs seem to win a lot throughout this whole process. They find ways to kind of make money in every single step. So PBMs sound like the big winners. Patients, independent pharmacies, they kind of sound like, the losers in this whole deal. And maybe the employers and providers are somewhere in the middle. They win sometimes and they lose sometimes. Is that a fair assessment overall?
That's fair, and we didn't even talk about who's transporting the drugs, right?
Oh,
So
yeah.
we didn't
talk about
even
that.
get into who's who's delivering from the pharma manufacturer to the warehouse, to the pharmacy, to the patient, and the money that's received in that whole
Well,
string.
there's
also.
another winner. Well, there's a couple other winners, because you mentioned that, there's 3 PBMs in the US that own 80% of the market. And there are well over 150 PBMs in the US. So why just 3? And the other winner would be consultants who consult with the employers on which PBM is going to give them the greatest value. It's going to cost the least, less, disruption, better service for their employees, because that's what employers care about. Want to make sure everyone gets their drugs so that they can come back to work and be productive. But there's recommending, more often than not, one of these 3 PBMs over a bunch of other ones that may or may not, maybe the other ones aren't very good, or maybe they're too good, or there must be a reason that they recommend those at a disproportionate rate.
Yeah, there's a reason, because they receive money on the back end from those PBMs. They can receive on a high level, at the corporate level, and at the individual consultant level. They also have their own contracts with the PBMs, so they've set up their own purchasing groups So where employers can all come together under a single contract, right? So they have a natural bias because they have a relationship with those PBMs.
But if that lowers the cost for the employer, that should be good for the employer.
Except it's not necessarily lowering the cost for the employer. So they spreadsheet all of this, and they have the ability to make the numbers work. So
In favor of their
in
group
favor of their
purchasing
group
consortium, if you will.
yeah, whatever lines their pocket.
Mike, I think you're hearing in the US, we have somewhat of a capitalistic society, and that's not different from, the healthcare space, especially, as we're talking about pharmacy and pharmacy benefits and, how a drug actually gets to a patient.
Yeah, and I think that's fine as long as it results in better patient outcomes, right? And reduced costs across the board. But obviously, it's not resulting in all of that. And so there is a disparity where costs are going up, but patient care is going down. So
Yeah.
that's why I think if you had to boil everything down, that's why we talk about the system being fundamentally broken. And I think what we'd love to know is, and I know this type of thing is very near and dear to both your hearts because you're working hard to create some more equity in the system. So talk to me about some of the strategies overall, just generally, that are being pursued to address these issues, improve patient outcomes across the board. And then tell me a little about your work with the Washington Health Alliance and what you're doing sort of on a micro level. So let's start on the macro level and then let's go down to the micro level.
Yeah, I think on the, healthcare, in the US, we see a lot of health disparities based on income and in particular about where someone lives. And unfortunately, can be the color of their skin or the language that they speak. And that's prevalent around, across the US. And one of the things that we're doing at the Alliance is we want to use data to help tell that story and also to highlight where opportunities exist. So we actually bring in a lot of claims data, about 2/3 of the population in the state that we live in, Washington. And we can interrogate that data, and we can look at it from a variety of different points of view, whether it's a total cost, specific clinical outcomes, et cetera. But one of the other ways we can look at it is care different depending on where you might live? And we see fairly clearly that in the lower income, if you will, or more deprived neighborhoods, clinical care quality is worse. People avoid care more often. You talked about the affordability of care. In the US, about right around 50% of the population is rationing the care they receive. They're rationing because they got to pay for housing, they got to pay for food, they got to pay for their kids and their clothing. And when transportation, and when it gets down to healthcare, 50% of the population says they ration the care that they receive. The most common care they receive is actually on the pharmaceutical side. It's the most frequent that comes up. And what you end up seeing people do is trying to spread their doses out, which we know doesn't work. So you have very poor adherence or just non-adherence. So you might have prescribed something once a day and they take it every 3 days. The pharmacists on on this podcast are going to say, well, that's not going to work. And it doesn't, because you need at least 80% adherence to, have any clinical efficacy. So, we find that the whole system of having people have to shell out, money that they may not have, can be very problematic in terms of delivering high quality clinical care, that gets exacerbated based on the income level people are, because it impacts them at a higher rate than others. And we see in our data that that's increasingly problematic for those populations for a variety of reasons. I think, part of your other question is, what do we go ahead and do about that? I think it goes back to, where we started a little bit in terms of, the reimbursement methodology for care in the U.S. evolved over the last, 80 years in such a way that, we ended up paying for widgets, and we paid, we have systems in place that is not necessarily fair for everybody, and creating a more fair and just coverage system would make a lot of sense, to have, make sure that things are covered that people need, that they, remove those barriers, right? If it's a financial barrier, we got to remove that. If it's a transportation or an access barrier, we have to remove those things so that people can actually get the care they need. That would improve productivity, in the country. It would improve the cost for an individual, but overall, it should lower the total cost of care in general. I think, there's a lot of work when you talked about, Medicare for all. It's sort of that calling, but it's really a calling to say, we should be like all but one other industrialized country in the world, that we should have 100% of our population have access to healthcare equally, and that the cost shouldn't be something that puts them into bankruptcy.
Well, let me ask you a question. If you could wave a magic wand, I give you the power right now to change one thing about the system. Just one thing that you think would, if you could change it, would have an outsized impact on patient care, patient outcomes, cost of care. What would that one thing be? And that's to both of you.
I think we're going to say the same thing.
Maybe. Go ahead.
I was going to say global payment for primary care.
Yeah, I would say the payment model is one way to help align, actions. And because what you pay for is what happens. That's what gets done. And what we get today is we pay for widgets. And so, you do more widgets. And if we just paid for the right care, regardless of how many widgets you do, I think it's not only global payment for primary care. I would say it's either a global payment or an episode-based payment. So really changing the payment methodology. If I had another magic wand, I would do something that wouldn't be palatable in the U.S., which is I would federalize all of healthcare, remove all insurance companies. All providers would be like the post office.
That might not be a good comparison.
Maybe not the post office, but
Everyone loves going to the post office, right?
But they would, you would do it in such a way that people would work, because the training is fine. It's just the incentives are wrong, and you want people to do what they were trained to do, and the providers want to do what they were trained to do. If there's too many of them or they're incented the wrong way, they tend to. That influences how they behave, and so changing that would make a lot of sense.
All right, excellent. Well, I think we'll leave it there for our discussion. I want to ask you one last thing. Is there anything personally that you wanted to talk about? Something a little bit more extracurricular? Dr. Oliveira, you know where I'm going with this. You are a jazz musician as well as being a physician and health leader in the industry. And I am one of your fans, a fan of your music. Is there anything you want to tell us about that? Denise, if there are any extracurricular activities you'd like to talk about, by all means, you've got a active listening base here.
Well, I think anything people do curricularly are pretty fun. And I think everyone should do something that's enjoyable and brings joy to their life. And if it brings joy to other people's life, even better, because that sort of helps you continue to be curious and continue to learn and brings a little joy to your life. And I think, we all do different things, whether it's exercise or whether it's music or whether it's, if you're athletic and you like to go run or you like to go hike or you like to go walk the dog or something, all those things are really important to do to develop, and make sure you have a good balance in your life.
Yeah, I'm balancing mine between dancing bachata and playing pickleball these days. Yeah, and so I'm learning the pickleball culture. It started here in Washington on Bainbridge Island, and it's very interesting. A game that's fun that can also be quite serious for some people.
Absolutely.
Dr. Oliveira, Denise, thank you so much for your time today and for this vibrant discussion. I think I've definitely learned a little bit more about the industry and the challenges and maybe some of the opportunities. So I really enjoyed the conversation. Thank you so much for taking the time to be here on the podcast today. Thanks for joining us today on the Pharmacy View podcast. And don't forget to like, share, and leave a comment if you found this episode of value or have any feedback. Podcast episodes are promoted through social media, LinkedIn, YouTube, and major podcast mediums. And each episode can be found on the Pharmacy View webpage with links to guest contact and business details. If you're a pharmacist or industry support supplier and would like to join us on an episode, send us a message through LinkedIn or complete the inquiry form on the Pharmacy View webpage. I'm your host, Michael Alexander, pharmacist and co-founder of the communication intelligence platform Audirie. On behalf of Shopfront Solutions and Arion Technologies, thanks again for joining us today on the Pharmacy View podcast.